As a reminder, this briefing is being recorded and live streamed. For this reason, members will be asked to turn on their video when they are recognized for questions. Staff should keep their videos off at all times. All members have been placed on mute and are respectfully asked to remain muted until they are recognized by the chair for questions and are unmuted by the host. Members will be recognized in order of seniority for 5 minutes of questions each. Time will be kept using a digital timer which will be displayed on video for the convenience of members under the username 0-timer. Members who experience any technical difficulties should notify Select Committee staff as soon as possible using the chat box located under the participants panel or by email. At this time, I will turn it over to Chairman Clyburn, who will wait 60 seconds to begin to ensure the live stream is running.
Let me begin by thanking our panelists and members for joining us at today's briefing. 40,000. That is the latest estimate of how many Americans in nursing homes and other long-term care facilities have lost their lives as a result of the coronavirus pandemic. The men and women who died at these nursing homes were parents and grandparents who sacrificed to provide for their families. Some were veterans who fought to protect our country. Many were essential workers who kept showing up to care for the elderly and the sick, even when it meant risking their own lives, as our nation faced more deaths from coronavirus than any other country on earth. So let's be clear. These 40,000 Americans deserved better. Their deaths represent a failure of our nation to protect our people. There were warnings. In February, the coronavirus attacked the Life Care Center in Kirkland, Washington. 3/4 of the residents at that facility became infected, along with dozens of staff. 37 people died. 4 months later, nursing home residents, all workers have been infected in every single state in the country. Nursing home residents have died from the virus in every state in the United States of America. Many of these deaths could have been prevented, and we must ensure more lives are not lost unnecessarily. We know that personal protective equipment like masks, gloves, can help stop the spread of the virus. But without a comprehensive national plan to acquire and distribute PPEs, many nursing homes ran out. Others were forced to reuse masks, create their own, or go without. Even today, these shortages continue. Federal data shows that more than 500 nursing homes lack N95 masks. More than 250 nursing homes have run out of surgical masks. and another 800 are close to running out. Hundreds of other nursing homes face critical shortages of gowns, hand sanitizer, and other supplies. We know that rapid and frequent testing can save lives. Last month, the Centers for Medicare and Medicaid Services recommended that nursing homes test all residents and staff. But without a comprehensive national testing plan and distribution of testing supplies, nursing homes in at least half of the states are unable to conduct the recommended testing. We all know that healthy, safe nursing homes need to be fully staffed with workers who are treated well and paid fairly. Yet, many facilities have cut staffing to boost profits, while paying workers little more than minimum wage and providing no health insurance or paid leave. Think about that for a moment. If a nursing home worker feels sick, they may have no choice but to report to work anyway, or risk losing their only means of supporting themselves and their families. We must do better. I hope that today's briefing will help lead us to simple, clear steps that the federal government can take now to protect vulnerable Americans in nursing homes who are relying on us to get this right. That includes stronger oversight and more federal leadership on testing and protective equipment. Today, we will hear from briefers about the suffering at our nation's nursing homes. I'm particularly grateful to Allison Lally, whose mother tragically died after contracting the coronavirus in a nursing home in Monroe, Louisiana. Ms. Lally, thank you for agreeing to join us today to share your story. I also want to recognize that members of our committee have been personally affected by the coronavirus crisis in our long-term care facilities. Chairwoman Waters, I want to thank you for joining us in this important briefing, and again, extend my deepest condolences for the loss of your sister. Now, I am aware that some have tried to make deaths in our nation's nursing homes a partisan issue. I hope we won't fall into that trap today. Nursing home residents have died from the coronavirus in states governed by Republicans and Democrats, in big cities and small towns, in rural and urban communities. What unites them is that they are all Americans, and our nation's government must take responsibility for keeping them safe. With that, I will turn to the distinguished ranking member, Mrs. Scalise, for his opening remarks. Mrs. Scalise.
Thank you, Mr. Chairman. I appreciate you calling this important hearing. As we face the very serious challenges before us, I first want to start today with some positive news. After a long and difficult few months, the American recovery is finally underway. All 50 states have finally begun reopening. Last week, we just got the May jobs report. And instead of what was expected to be a 7.5 million additional jobs lost, instead, we shattered the post-World War II record by creating 2.5 million new jobs in May. That's a swing of 10 million jobs to the positive. The Paycheck Protection Program that we passed together, Republicans and Democrats working with President Trump, has made loans now to more than 4.5 million small businesses. And that's over $500 billion in loans to save millions of American jobs for those hardworking families that enjoy them today. Clearly, the work we have done together has helped Americans make it through some of the toughest times in our nation's history. And now we're seeing the American people burst out of their homes with energy and determination to get back to work and to make America a more perfect union. Today's weekly unemployment claims remind us that we still have work to do. Our job now is to keep this recovery moving forward. While we know the virus is still out there, we also know that we've turned a corner in our response. We've conducted more than 3.2 million tests just in the past 7 days. Production and delivery of PPE increases daily. The private sector, FEMA, and HHS have delivered tens of millions of N95 respirators, surgical masks, face shields, and over 1 billion surgical gloves have been delivered. Under President Trump's leadership and direction, the FDA has expedited promising therapies and vaccines that are being tested as we speak. Make no mistake, COVID-19 is an insidious and evil enemy. As today's hearing underscores, this hidden enemy attacks the elderly at an alarming rate. Our job is to protect those most vulnerable. Nursing home residents make up only 0.6% of the American population, yet they have accounted for over 40% of the national COVID-19 deaths. This is unacceptable, Mr. Chairman, and more sadly, this was largely avoidable. The decision of several governors to essentially mandate that COVID positive patients go back to their nursing homes, even if those nursing homes were incapable of properly treating them, ended up being a death sentence. New York has suffered 6,299 deaths in nursing homes. For New Jersey, it's more than that, 6,309 deaths. Compare that to Florida, which is a retirement state, which had less than 1,500 deaths. All tragedies, but wide disparities. On a per capita basis, nursing home deaths in New York are 500% higher than in Florida. In New Jersey, it's even worse, over 1,120% higher than in Florida because of those decisions. Other states like Michigan, California, and Pennsylvania that forced COVID positive patients back into nursing homes have had similar tragic disparities. Today, Mr. Chairman, we should be focused on what went wrong to stop that from happening again. Let's walk through what happened. On February 6th, CMS released this first guidance for COVID positive nursing home patients. The administration had seen that we were beginning to have this unfolding in Europe, and they took quick action. On February 29th, America experienced the first nursing home outbreak in Washington state. On March 13th, CMS updated its guidance to continue clarifying how to treat COVID positive patients that were discharged from hospitals. CMS Administrator Seema Verma said, quote, under no circumstances should a hospital discharge a patient to a nursing home that is not prepared to take care of those patients' needs. That was a clear directive. But unfortunately, on March 24th, Governor Cuomo's health department issued this directive in contradiction to the CMS guidance by mandating that nursing homes take COVID-19 positive patients. New Jersey essentially copied verbatim the same directive from New York's order with similar deadly results. 2 weeks earlier, Governor DeSantis in Florida prohibited transferring COVID-19 patients who were positive from hospitals to nursing homes. Very different orders yielding very different results. On March 18th, Pennsylvania also issued guidance mandating that nursing home patients continue to accept new admissions and readmissions, including patients that were COVID-19 positive. While defending this decision, even Pennsylvania's health secretary moved her mother out of a nursing home. On April 15th, the governor of Michigan issued a similar executive order mandating that nursing home patients have to be accepted regardless of COVID-19 status, even if they couldn't properly take care of them. Again, in contradiction to the CMS directive. Michigan State Representative, who's a Democrat, Leslie Love, actually criticized that decision publicly, calling this reckless order, quote, an epic fail. Mr. Chairman, shockingly, this order in Michigan still remains in effect today. I'm calling on Governor Whitmer to rescind this order immediately. And I hope all of my colleagues join me in calling on this to be rescinded because it is having deadly, devastating consequences for seniors who are COVID positive in nursing homes. I've drafted letters for each of these governors requesting information on what led to these tragic decisions. I would ask all members of this subcommittee to sign on to this letter so we can get that information and prevent more unnecessary deaths from occurring. Let's work on a bipartisan basis to get all of this information out there to ensure that these deadly mistakes are not repeated. Again, Mr. Chairman, look, the American people are deciding to get back out there, to reopen the economy, to get back to work so that they can rebuild and get their jobs back. It's time for us to stand together for justice and equality. To do this requires that we protect those most vulnerable to this virus. We must turn a bright light of sunshine on the mistakes that were made so no more needless deaths occur. With that, Mr. Chairman, I yield back.
I thank the ranking member. Let me once again welcome our panelists and introduce the public health experts and community leaders who are with us today. Thank you again to each of our briefers for joining us. We will hear today from Allison Lally, who I introduced earlier. We will also hear from Chris Brown, a certified nursing assistant who works at a privately owned nursing home in Chicago that was ravaged by the coronavirus pandemic. Mr. Brown has seen firsthand how shortages of personal protective equipment and testing have contributed to an outbreak, and he has experienced the stress of working in a dangerous job. Also with us today is Eric Carlson, Directing Attorney at Justice in Aging, a nonprofit organization that advocates for affordable health care and economic security for our nation's seniors. Mr. Carlson will discuss how the federal government can better protect Americans living in long-term health care facilities. Next, we will hear from Phil Kerpin, who serves as president of American Commitment. Finally, we will hear from Professor David Grabowski of Harvard Medical School, who has studied nursing homes for many years. Professor Grabowski will talk about why nursing homes have been devastated by the coronavirus and what steps we can take today to prevent further outbursts. I would like to recognize now Ms. Lally for an opening statement. Ms. Lally.
Good morning, Chairman Clyburn, Ranking Member Scalise, and subcommittee members. My name is Allison Lally, and I'm the daughter of Cheryl Fink Lally. My mother died in April in a nursing home in Monroe, Louisiana. I'm grateful for the invitation to share my family story here today, and it is my sincere hope that it will assist you as you execute on the charge to have robust oversight of the federal resources expended in response to the COVID-19 crisis. My mother was admitted to the Oaks Nursing Home on December 31st of 2019. The Oaks, a 5-minute walk from our family home, allowed us to truly oversee Mama's daily care and create an opportunity to visit her frequently. The only concern we had was heavy staff turnover as she was admitted. First the administrator, then the director of nursing, and a social worker. This created anxiety for our family, so much so that I reached out to the Oaks owner for help in navigating an untenable communication and administrative process. It was a harbinger of problems to come. On March the 5th, I received a letter from the Oaks via regular U.S. mail and signed by the director of operations, who was filling in while management worked to recruit a new administrator. The letter acknowledged presumed COVID-19 concerns amongst family members and shared the steps they were implementing to help reduce the potential for the virus to enter the building. At some point before March 11th, another letter arrived. This letter included the following language. At this time, we request that family and friends do not visit the facility. The letter went on to reinforce that the facility was following the recommendations of the CDC on prevention steps and that they were in close contact with local and state health departments, and they were following their guidance. My family made the conscious decision and commitment to follow the requests of the Oaks. We began to see vacillating practices by the staff, and Mama began to look disheveled. She would gently complain that things didn't seem right, and on more than one occasion, she shared that she was not fed a meal all day. On the early morning of Friday, April 17th, I went to the mailbox and found a third letter from the Oaks, dated April 13th. The letter informed us that an employee of the Oaks had tested positive for COVID-19 and gave specific instructions as to when we could call if we had questions and with whom to speak. I made my first call to the facility at 10 a.m. as directed. I was transferred to the RN's voicemail. That process went on until around 2 p.m. When I never heard back, I texted the director and was told that the RN had been slammed with calls and that they were doing their best to return them as quickly as possible. I began asking questions. What was the job of the COVID-19 infected employee and what interaction did he or she have with my mother? Were there any other cases in the Oaks? And what was the procedure around removing my mother from the Oaks if we wanted to make that choice? Then, unsolicited, I was told by the director that while she could not guarantee anything, she felt confident that they were past it. There had been a period without any additional infections and that she personally had evaluated the entire situation. We decided to keep Mama in the Oaks as long as there were no more cases. The director agreed to respond to my text messages twice daily with an update on cases. From the morning of April 18th at 7:29 a.m. until the evening of April 20th, I texted twice a day, and each time I received the answer that there were no new cases. On April 21st, I sent my text, no reply. I texted again and asked if everything was okay. I got a text that said, "I'm okay, unbelievably busy, residents are good." I asked again about new cases. Her reply was, "The best way to help me work effectively is by limiting calls and texts. I assure you that you will be notified of any changes. Our residents and staff deserve my full attention, and I will continue to answer the call when your mom needs assistance with her care." Throughout this harrowing experience, I spoke with every resource I had within the Oaks facility regarding their lack of communication. The residents' families needed consistent, factual information to help make decisions. I was met with little to no interest and no commitment to transparency. Our family continued to watch Mama deteriorate. She complained of lack of care, attention, and manhandling from people in her room who she did not recognize. During one visit to her window on April 19th, I found Mama unclothed, unkempt, and confused. On April 23rd at approximately 2 p.m., I received a call from the Oaks. Terrified of what I was about to hear, a nurse told me that my mother was being transferred to the hospital. The nurse stated that she had returned to work at the Oaks, and when she saw my mother, she didn't look right. She also shared that Mama's O2 sat rate was dropping and she was confused. Mama was transferred to St. Francis Medical Center and admitted to the COVID unit. Mama died in the unit on April 29th at 5:05, and she was alone. In closing, let me acknowledge that I have kept myself abreast of the data and statistics, and I understand all the factors that led to the impact of the coronavirus on nursing homes. Regardless, there was plenty of time to prepare. The first nursing home cluster was documented in Seattle in early March, but I could not get any hard facts on nursing home cases in our parish, nor could I get any level of comfort regarding a plan. The fact is, my family was robbed. Mama was trapped in a petri dish and we were shut out. Mama died alone, and our family will forever be scarred by this tragedy. I implore each of you to continue your due diligence. Evaluate best practices like we see coming out of Florida. Find the caregivers within the nursing homes who can tell you what really happened inside when they witnessed firsthand the care for our most vulnerable and treasured loved ones. The Oaks is a for-profit business that was not prepared to handle the crisis due to excessive turnover in staff and a lack of established disaster protocols. They lacked a communication plan that allowed families to make informed decisions. Please reform this industry, properly fund this industry, and do it quickly. Let's not let my mother die in vain. Thank you.
Thank you very much, Ms. Lally. I want to now recognize Mr. Brown for an opening statement. Mr. Brown.
Thank you. Good morning to the members of this committee. Thank you for allowing me to share my story today. My name is Chris Brown. I am a nursing home worker from Chicago, Illinois. I'm also a proud member of the STIU, Illinois, Indiana, Michigan, and Kansas. I've worked in the healthcare industry for almost 10 years. The first person I took care of was my grandfather with cancer. It was an entire family effort. When someone had to work, I was there making sure he had his medicine and was well taken care of. I was happy to help him and keep him at his best possible spirits. This is and was inspired to keep me and make me want to work in nursing homes. Although the work is very rewarding, I along with my other nursing home workers face many challenges. And the truth is, these challenges and these things was going on before COVID ever existed. One of those challenges are short staffing. I worked on a floor where the residents are bedbound, they cannot speak, they cannot move. It takes lots of physical labor to take care of these residents. We move them, make sure they don't get bed sores, we change their linens, and we change their soiled garments. Short staffing means less help. Now, with COVID-19, short staffing also means we were coming into contact with more residents, even when our facility created a specific floor for residents who were infected with COVID-19. Short staffing means nursing home workers were being spread thin. When workers come into contact with more residents, the risk of exposure for COVID-19 is heightened. We don't know if the residents are tested when they arrive, if the residents are only tested if they show symptoms. By then, it may be too late. If I become sick, how can I take care of somebody else? Who will take care of me? If I end up working sick, the virus could spread like wildfire. If I don't come in, I risk not being able to pay my bills. If I have to choose between keeping the lights on or protecting my health. Being given low-grade PPE compounds these risks. I have more direct contact with residents than medical staff at nursing homes where I work, and I'm given a single-use mask. Some nursing home workers resort to saving their masks in paper bags as a way to ration them. What is worse, we did not have the policies in place to tell us whether we were working with residents infected with COVID-19 in my facility. I had to wait 4 weeks between the first case of COVID-19 appearing and the time I knew. I never knew whether I came in contact with the patient. If I was scared, I was scared that entire time and eventually had to move out of my house because I was afraid of getting my family sick. I haven't seen them since. It's difficult not to be able to see your family. I have 13 brothers and sisters. We all work to take care of my grandmother who has dementia. Every day, my grandmother is losing a bit of herself. And in these last precious moments, I'm going to miss because of COVID-19. But the time I have been spending with my grandmother, the time I haven't been spending with my grandmother, I'm developing relationships with people in the facility. Unlike my grandmother, many of these residents don't have family members. Sometimes we end up becoming the only family they know. So I spend time telling a good joke, putting a smile on the residents' faces and keeping them company. That's why we need to invest in nursing home workers and residents and address short staffing and both heavy emotional and physical labor. But it's easier to find people to do this work if they are paid what they're worth. If we value this work, our residents can live with dignity and comfort. There have been efforts at my facility to bring in new people, but unfortunately, these workers are too undertrained to provide the kind of help we desperately need. At most, they can pass out trays and they don't qualify to be in direct contact with residents. We need better training standards. Together with my union family, we have been able to make some progress. Nursing home workers across facilities lobbied in Springfield, Illinois, and shared our stories of being understaffed and working without benefits. Just recently, we were able to win pay increases for nursing home workers in Chicago after 5,000 people threatened to go on strike, including the $2 increase for hazard pay and an additional 5 days paid sick day. But it's still not enough. All these issues I mentioned are still there. These issues are not unique to my facility. Nursing home workers across the country say their residents are not adequately protected from COVID-19. They are also calling for paid sick paid sick days, double time hazard pay, and free testing for COVID-19. With the pandemic disproportionately affecting communities of color, and acknowledging the majority of nursing home workers employed in these nursing homes are Black and or of color, nursing home workers are getting hit hard. I continue to hope and pray for this change to be better. Our families depend on it. And I want to thank you guys for letting me speak.
Thank you very much, Mr. Brown. I would now like to recognize Mr. Carlson for an opening statement.
Thank you. My thanks to the chair, the ranking member, and all subcommittee members for the opportunity to be with you today. As has been noted, the pandemic has without a doubt taken a terrible toll on nursing facilities, on nursing facility residents. Over 40,000 deaths. This is approximately 45% of the total number of deaths in the country, which is a shocking number. And as Mr. Brown just noted, there's been a disproportionate impact on people of color. There's a couple of interrelated questions that are important to address today. Why has there been, as is mentioned in the title of today's briefing, such a devastating impact on nursing facility residents? And then secondly, of course, what can the federal government do to address this problem now and in the future? First, I would suggest that we look at the longstanding quality of care problems in many nursing facilities. I work with nursing facility residents and on nursing facility issues for 30 years. Some facilities provide good quality care, but they're often the exception. Facilities frequently are short-staffed, as Mr. Brown and Ms. Lawley noted, which puts nurse aides like Mr. Brown in a no-win situation. They're responsible for too many residents, so they don't have time to give residents adequate attention. The Government Accountability Office recently released a report on facilities infection prevention practices, which is obviously incredibly relevant to what's going on now. 82% of facilities were cited for at least one infection prevention deficiency during a 5-year period. And almost half of those cited facilities had committed a violation in multiple consecutive years. Every time the inspector showed up, the GAO described these findings as indicators of persistent problems. And these are the kind of persistent problems that have manifested now, this year, in COVID-19 infections and deaths. Quality of care problems have been exacerbated, as Mr. Brown noted, in this instance, as the chair noted, by difficulties in obtaining personal protective equipment in COVID-19 tests. I expect Professor Grabowski will have more to say on this topic, but I want to point out the lack of federal coordination that certainly has impeded facilities' ability to identify infected persons and to provide care. In particular, that absences remains important as facilities are attempting to open up, which requires an extensive reliance on testing to identify infections or lack thereof. I'd like to flag some other areas where improvements in federal policy are important. There is general consensus at this point that it's beneficial to house COVID positive residents with other COVID positive residents. And to facilitate this kind of cohorting, CMS has waived eviction protections essentially in nursing facilities so that facilities have discretion to transfer residents in and out to a great extent, and to decide, the facility to decide if it's going to be a facility specifically for COVID positive residents. This discretion, relatively unfettered, given to facilities, puts residents at risk in a couple of ways. First, they may not receive any notice whatsoever under the federal waiver before being transferred out. And that facility that they're going to may have essentially nominated itself to care for COVID positive residents, even though it may provide a low quality of care. And I note in my written statement, which I've submitted, some poor performing facilities indeed have put themselves forward, promoted themselves to care for COVID positive residents. Suggest that there's a role for the federal government and CMS here to provide some type of advance notice for residents so they have some control where they're to live. And also CMS should set some minimum standards for these facilities that focus on COVID positive residents. These are residents who obviously are incredible risk, and we should make sure that their care is of the highest standard. Another beneficial upgrade is the role of infection preventionist in nursing facilities. Under the current federal regulation, it's just a part-time position. And there's no specification in talking about part-time, whether this is 2 hours a week, 10 hours a week, 30 hours a week, entirely discretionary. And as a practical matter, I would submit in most nursing facilities, this is just a facility nurse who's taken on an additional designation as infection preventionist. Given the risk of COVID-19, this role, this has to be expanded significantly with the position upgraded to full-time or close to full-time with a commensurate increase in responsibilities and in training. Note that California already is requiring, as part of facilities mitigation plans, that infection preventionists work on a full-time basis, and pending House legislation would require the same. So I know I submitted a written statement that has 10 issues, and obviously I don't have the discretion to discuss all of those, but I'd like to close by pointing out how CMS has waived nurse aid training standards during this emergency. And Mr. Brown referred to some folks who don't have adequate training in the facility right now. Ordinarily, a certified nurse aide, like Mr. Brown, can provide hands-on care in a facility only after completing an initial 16 hours of training. And then within the first 4 months of employment, the nurse aide has to complete 75 hours of training and pass a skills examination. But those requirements have been waived completely right now. There's no training requirements whatsoever. It's important that CMS reinstate these training requirements. At this point, the risk of not having enough nurse aides is outweighed by the risk of direct care staff, of direct care being provided by persons who simply don't have the adequate training. They don't have the adequate training or experience. And there shouldn't be any grandfathering of people who've been brought in with essentially no training. Now is the time to reinstate those standards to make sure that the quality of care is high. And again, I very much appreciate the opportunity to speak with you all today. It's an incredibly important topic, and I applaud your interest in improving federal policy in this area.
Well, thank you very much, Mr. Carlson. I would now like to recognize Mr. Kirpin.
Hi, thank you so much for inviting me and for having this hearing. It is, I believe, the most important subject for Congress and for our country and for the media to be looking at right now, and really overall at any time with respect to this pandemic, because this is overwhelmingly the population that is at risk and the population that is dying from this disease. And we've heard a lot of numbers. A lot of people have used the 40,000 number or the 40-some% number. Those come from large media studies or the CMS data, perhaps. But we've been compiling the state source data every single day. And the state source data already shows significantly higher numbers than that. We have the number now of national COVID deaths in long-term care facilities, excluding the state of New York, and I'll explain why we do that in a moment. We have it at about 55% of all of the COVID deaths nationally, so a pretty clear majority, and it's been rising. And if you look at a lot of the states with the most complete data, it can be as high as 60 or 70, or in some cases even 80% in states like Rhode Island and Minnesota of the deaths are among the population of long-term care facilities. And that actually shouldn't surprise us. If you look at the age stratification table that I included here in the written testimony, this is based on the new CDC data that was released yesterday. And we now have in this country about 60% of all COVID deaths above age 75. And it's an extremely steep age stratification, kind of all the way through. Really, you don't have any significant number of deaths until you get to at least age 45, and there it's still less than deaths from other causes. You don't have more COVID deaths as a percentage of deaths than you have deaths from other causes, non-COVID deaths, until above age 65. And so we really need to focus on the older population, and we know where many of them are and the most vulnerable of them are, and that's in the nursing facilities. And of course, we should have known this even the pandemic came to America, because those were the people who were dying in China, those were the people who were dying in Europe. Almost every European country that has good data has more than half of their COVID deaths among residents of long-term care facilities. And yet, we've pursued the most expensive possible policy response, locking down the entire society, closing schools, despite the fact children are at far less risk of COVID than seasonal flu. We shuttered millions of businesses. We frightened low-risk adults and children, all in the name of saving vulnerable seniors. while at the same time sending infectious patients into nursing homes, doing the worst possible policy response if you're trying to protect the truly vulnerable. And one of the most disturbing facts to me about one of the worst job reports we've ever seen, probably the worst job report we've ever seen in our lifetime, was the April job report showed nursing homes shed 113,000 employees in that month, in that most crucial month for them to be able to deal with this. They were losing a massive number of employees. I think we need to learn more about why that happened, whether it was just the economic crash collapsed everything and there were layoffs everywhere, including them, whether school closures forced people to stay home with their children. That's a key part of this puzzle to figure out why that happened. We have data on all of the states, which is included here. I won't run through it, but I want to talk about 7 states in particular. There are 7 high volume mortality states that together account for about 65% of all of the COVID-19 deaths in this country. Those are the 5 northeastern states, New York, New Jersey, Connecticut, Pennsylvania, and Massachusetts, and the 2 Midwestern states, Illinois and Michigan. And you'll note these are not the largest or most populous states, but these are the ones that overwhelmingly have most of the COVID-19 deaths. And what they have in common, to get to the point that the ranking member was making in his opening statement, is they all adopted some version of the policy of requiring nursing homes to take infectious patients in post-acute care, whether they had the ability to properly isolate them or not. And I believe that that was the key policy error that led to large volumes of deaths in those states. New York is very interesting because New York does not report the number of long-term care residents who died, unlike every other state. They only tell us the number that died in long-term care facilities. Of course, the majority of residents who die are hospitalized prior to death. And so the 6,300 number that we have from New York is probably half or even a third of their total long-term care deaths. That's why I think to look at the burden, you have to exclude New York. If New York would give us an honest number, and interestingly, they used to report the same as all the other states. At the end of April, they changed their reporting metric, added that footnote, and stopped giving us the real number. I think it's critical for Congress to understand the scope of this issue to get that real number from New York, and they really need to be pressed on that. The ranking member ran through a lot of the policies that were adopted by these states that I was going to run through, so I don't think I need to do that. But I want to quote from a doctor who's a medical caretaker in Pennsylvania who tried to get hospitals to take his patients. And he wrote, 2 weeks into the lockdown, Philadelphia hospitals had been emptied, waiting for a New York-style surge that never came. But at this point, the nursing homes had started to see their first infections. We asked the Department of Health to allow us to test everyone at the nursing home in order to effectively cluster everyone with COVID in one unit. They refused. We asked to utilize the large room to cohort patients. DOH said this wasn't possible. I spoke to a nice hospitalist at another large health system who was very receptive to the idea of boarding COVID patients from the nursing home in the half-empty hospital to avoid the entire nursing home eventually becoming infected. An email chain followed to get permission from administrative units. Absolutely not was the answer. I was told the more fruitful endeavor was to discuss advance directives with the residents. The implicit message, keep the residents away from the pristine hospital. If they get too sick, hopefully they don't need to be resuscitated. It's sad. And Pennsylvania now reports about 69% of their total COVID-19 deaths among nursing home residents, about 4,200 deaths as of their most recent report. And really, it's those 7 states that all adopted versions of this policy where they have 50, 60, 70% of their overall deaths, where it was the driver of spread. They became the nexus of spread, driving the non-nursing home deaths as well. And that accounts for the majority of the deaths in this country, the supermajority, in fact, from those states. So I will leave it at that. I have run out of time, but I also cover in the written testimony a lot of the states that did much better with the same resources, deployed them much more effectively, and had much better results. And I hope that if we see another increase in spread or a second wave, we will target the help and the resources and the intervention to the people who are truly at risk and not much more expensive, less effective society-wide approaches. Thank you.
Thank you very much, Mr. Kirkman. The chair now recognizes Dr. Grabowski.
Great, thank you. Chairman Clyburn, Ranking Member Scalise, and distinguished members of the subcommittee, thank you for convening this important conversation to address nursing homes and this pandemic. Let me start by being blunt. COVID has completely devastated U.S. nursing homes. Over half of the 15,000 nursing homes nationwide have reported cases among their residents and their staff. Over 40,000 Americans have died in nursing homes, and many of us think the true number is much higher. Just 0.4% of the entire US population represents nearly half of our country's COVID fatalities. Efforts to stem this plague are taking a huge toll. Nursing homes are in all-out lockdown. Because visitors are banned, family members have been unable to see their loved ones going on 3 months now. Staff are frightened given the lack of COVID testing and personal protective equipment, or PPE. And for good reason. New federal COVID data suggests nearly 700 staff nationally have died from COVID. Facilities are experiencing severe staff shortages as many individuals are unable or unwilling to work in these conditions. We hear a lot about the heroes working in hospitals, but individuals working in nursing homes like Mr. Brown, who are making close to minimum wage and risking their health, they are heroes too. Nursing homes have been underfunded for years and struggled with staffing and other issues prior to COVID. In many respects, COVID is, to quote a colleague, a crisis on top of a crisis. So what do we do about all this? Well, first we need to determine why COVID has entered certain nursing homes and not others. Some are suggesting COVID is a bad apples problem and are quick to point fingers at ineffective state policies or poor nursing home practices. However, our research and the research of colleagues at Brown University and the University of Chicago suggest COVID cases are not concentrated in low-quality homes or in states with particular policies. Rather, cases are concentrated wherever COVID is present in the community. The secret weapon behind COVID is that it spreads in the absence of any symptoms. Visitors have not been allowed in most facilities since March, but staff unknowingly bring the virus from the community into the facility. Thus, if COVID is in the community where staff live, COVID is soon to be in the nursing home where they work. This suggests COVID is not a bad apples problem, but rather a system-wide problem that can impact any nursing home in any state. This is a time to support all our nursing homes. So what should we do? Staff and residents are in desperate need of COVID testing. Until we get rapid and accurate testing for all staff and residents, we won't be able to contain COVID. And this can't be a one-off. We need a surveillance program that regularly tests staff and residents in order to identify new cases as they emerge. The virus also spreads because staff lack PPE. There is a huge shortage of masks, gloves, and gowns that has led to staff reusing these supplies or simply going without. Rather than pushing the logistics and costs of testing and PPE to states and nursing homes, the federal government needs to own this issue. The federal government should set a consistent policy across all US nursing homes and then provide states and nursing homes with the resources to achieve it. And if we have testing and PPE in place, we would be able to move safely towards opening nursing homes again to family members like Miss Lally, who could have visited her mother. Another issue is supporting and growing the direct care workforce. Nursing homes need higher reimbursement for COVID cases to prevent layoffs and maintain staffing levels. Staff also deserve a wage that is commensurate with the risks they are taking. The federal government needs to put dollars in place that flow directly to workers in terms of hazard pay and other benefits. I want to conclude with a very simple statement. It didn't have to be this way. What do I mean by that? Much of the negative impact of COVID in nursing homes could have been avoided. However, rather than prioritizing the safety of the 1.3 million individuals that live in nursing homes and the staff that care for them, we failed to invest in testing, PPE, and the workforce. We allowed a problem that could have been contained to grow into a national crisis. Now that we are here, it is time for the federal government to make the necessary investment to mitigate the spread of COVID across all US nursing homes. We owe it to our parents, our grandparents, and the individuals that care for them. Thank you.
Thank you very much, Dr. Grabowski. We will now have 5 minutes allotted to each member to ask questions. And with that, let me begin the questions by asking Ms. Lally. Ms. Lally, you give some very emotional testimony about your mother. And I would like to know from you, what is the one thing that you would have liked to have gotten from the nursing home, what is the one recommendation you would like to offer as to what would make your experience with your mother a better one?
Thank you. Communication. Communication in real time would have, I think, helped me ask more strategic questions of local officials and state officials so that I could have pressed harder for testing.
Well, thank you very much. Now, I would like to ask Mr. Carlson. You testified about the racial disparities in these nursing homes. What steps would you suggest that the federal government will take regarding that issue?
Well, one initial step would be to be able to identify the problem better. That CMS and the CDC right now have demanded as part of transparency that facilities report infections and deaths in facilities, but this doesn't include any demographic information whatsoever. And that should be expanded so that we have a better sense of the populations that are becoming ill and passing away in nursing facilities. And then secondly, I think a lot of the broader policy proposals that we talk about are designed to improve care, particularly in facilities that have a disproportionate number of residents who are persons of color. This would include the increased staffing that Mr. Brown and I think support for staff that Mr. Brown and Professor Grabowski referred to. And also, I'd stand with Ms. Lawley by pointing out that there should be a more nuanced way to allow residents to remain connected with families, that particularly as this emergency has continued, the inability of residents to be able to communicate with family members has become incredibly difficult on a variety of levels.
Well, thank you very much, Mr. Carlson. I think I have time for one more question. If so, I'd like to ask Mr. Brown if he could offer just some suggestion as to how he feels from his experiences things could be done a little bit better to protect himself and the residents. Mr. Brown?
Thank you. I really appreciate that question. There's a lot that can be done that I probably don't have time to go over. One thing effectively, my problem is communication. Us being and working in these facilities, knowing when we have a COVID patient coming into the facility, knowing where they're going to be and what's the standards around how to deal with them, the appropriate PPE. Far as PPE, there was times being in there where I've worked and I had to put a garbage bag on to do the work because these people need to be taken care of. Having enough staffing. When we speak to staffing, we already have language around staffing and how many residents and or patients that a CNA can have per shift, and this is not being about at all. We're not getting enough towels, soaps, and things of that nature. So when it comes to it, for me, having the PPE that I need, being communicated on this, on what COVID is, how to deal with COVID, the best practices of COVID, having some standard in place would have helped me a whole lot.
Well, thank you very much, Mr. Brown. The chair now recognizes the ranking member for 5 minutes. Mr. Scalise?
Thank you, Mr. Chairman, and appreciate again the witnesses, your testimony. Ms. Lawley in particular, I just want to express my condolences for the loss of your mother, Cheryl, at the nursing home in Monroe. I represent in my district, I have the Lambuth House in New Orleans, and I think a lot of people early off, that was one of the nursing homes with the highest number of deaths per capita, probably around 25 deaths there. And, they stopped counting the way that we could find a true number, but devastating as well. We were able to get some guidance from CDC to help them out. But as you point out, a lot of that, not even being able to visit your mother, I can't imagine how tough that had to be. So my condolences to you. And let's use this to find out how we can do better. And that's really where it gets to some of the things I've talked about earlier. And I surely want to dig deeper into this question because we still have seniors dying at nursing homes that shouldn't be. Clearly with COVID out there, there are people dying, and people even that are shut in, staying at home, that are getting it. And we've definitely stemmed the curve, and we're starting to see a decline now. Our hospitals are not being overrun like some of them were, and now we're starting to reopen. And so we need to keep learning about this disease, and especially how it's had such a disparate impact on seniors in nursing homes. And I still look at the numbers, and this is about data and us finding out what we can do to do better. There were directives given out by governors that gave a much different outcome in their states than states where they didn't do this. And I cannot, to this day, when CMS put the guidelines out, CMS told states how to take care of seniors in nursing homes. And if you can't take care of your senior in an isolated way, if they're positive for COVID, then you shouldn't bring them back. And most governors did that, Democrat and Republican, but there were some. And Mr. Chair, and this is the thing that we need to be looking at, because we want to find out what happened, but we want to stop this from happening again. In New York, the governor literally gave a directive. It's dated here, March 25th. No resident shall be denied readmission or admission to the nursing home solely based on a confirmed or suspected diagnosis of COVID-19. Went on to say nursing homes are prohibited from requiring a hospitalized resident who is determined medically stable to be tested for COVID-19 prior to admission or readmission. And I know some people talked about the testing, and I'm with you there, but the governor literally prohibited the nursing home from testing. This led to thousands of deaths. Finally, after over 40 days, the governor of New York rescinded this order, thank goodness, but thousands of people died during this period. And if that wasn't going on, it would be one thing. We still should find out about it. New York still needs to be transparent with the numbers. I don't know why they stopped reporting those numbers. They're out there, they're recorded. We ought to know them. But then if you look in Michigan, the governor of Michigan did the same thing, and it's still going on. And I call on all members of this committee to join me in calling on the governor of Michigan to rescind this order. People are dying unnecessarily in Michigan in nursing homes, and we know now what the results are if you do this, and they're still doing it. My goodness, I mean, that has to end. And so I want to ask Mr. Kerpen, why do you think some of these orders were given in contradiction to CMS guidelines, and why are some of these still in effect, especially in a state like Michigan, and should that end?
Well, look, I think these orders were given for basically two reasons. One is these states were worried about preserving hospital capacity. They thought they could be overrun with hospitalized patients from the community. They wanted to keep those beds clear by getting nursing home patients out of them. And number two is they didn't have a better post-acute plan. They didn't have somewhere else to send them. And so they said, you've got to take them, you figure it out. And some of them, like New Jersey, did at one point adopt. They amended their order and said you have to be able to isolate them properly, and you have to cohort them. But a whistleblower letter from New Jersey said that the Department of Health knew that the nursing homes could not meet that requirement because they didn't give them adequate PPE to meet it, because they would rather give it to the hospitals that were more visible, and it was more important from a media standpoint. And the same thing with testing. They wanted to have public testing because they thought it was more important from a public relations and a media standpoint, rather than putting the tests where they could do the most good. And so this was a resource allocation error. And like that Pennsylvania story I read, in most of these places, they were trying to keep hospitals empty for a surge from the community that never showed up. And so the hospitals stayed empty while they were not serving nursing home patients.
Right. And look, knowing what we know now, look, CMS has given over 14 different guidances on how to properly do this. And Michigan's still in contradiction to that, and people are still dying. Knowing what we know now, is there any reason why it should still be going on in Michigan?
It's actually pretty crazy that Michigan is continuing with this policy of admission to these so-called hub facilities, which many people believe cannot properly isolate these patients and protect their non-COVID patients, because they have totally underutilized field hospitals that could be dedicated facilities for post-acute care, and that would make much more sense. That's what some members of the legislature there want to do, and I believe that's what the governor should do.
Thank you. I yield
Thank you
back.
very much, Ms. Scalise. Your time has expired. The chair now recognizes for 5 minutes, Ms. Waters.
Thank you so very much, Mr. Chairman. This is a very important hearing, but I want to address my first remarks at some statements that have been made by Mr. Scalise, who's talking about the decline in hospitalizations. That's not true. In Texas, North and South Carolina, California, Oregon, Arkansas, Mississippi, Utah, and Arizona, increasing numbers of COVID-19 patients are showing up in hospitals. For example, Texas has reported 2 consecutive days of record-breaking coronavirus hospitalizations. The state, which has one of the first to reopen, has seen a 36% increase in new cases since the end of May, with a record 2,056 hospitalizations recorded by Tuesday afternoon, the Post reported. Now let me talk about nursing homes. In an article from the St. Louis Post-Dispatch, employees of a nursing home were joined the State Health Care Workers Union on Monday in demanding paid sick leave and other protections after learning that a co-worker died of COVID-19. Cynthia Whitfield, 58, of Jennings, died April 21st of the disease a week after she was hospitalized at St. Mary's, said her daughter, Jasmine Whitfield, 25. A certified medical technician at Grand Manor Nursing and Rehabilitation. Cynthia Whitfield was awaiting COVID-19 test results when she told her employers April 10 that she was short of breath and severely fatigued, her daughter said. A handful of other employees had tested positive for the disease after an outbreak that sickened dozens of residents. And so, what are we talking about here? Grand Manor at 3645 Cook Avenue in North St. Louis is one of several nursing homes across the St. Louis area that have denied workers paid sick leave, hazard pay, and other protections, said Lenny Jones, a director and vice president of the union, which represents 4,000 healthcare workers. SEIU Healthcare is part of the Service Employees International Union, the nation's largest union behind the National Education Association. While Grand Manor announced April 20th it would pay extra $10 an hour to nurses, has not extended the offer to other employees, said Lester Doris, a housekeeper. We're all exposed to the same thing, said Doris, a father of 3 boys. I might not have to go in here and touch residents, but I do have to go in there and sanitize and clean all of the things that they have. Grand Manor did not respond to a request for comment. The homeowner, who is Mark Sousa of Chicago, did not respond to a request for comment. That is the nursing home my sister died in on May 1st. Now, I want to ask a particular, perhaps Eric Carlson, about these nursing homes, the level of profit. How much support do they get from the states and the feds? There's always been a problem. They have the lowest paid workers, and these people are doing the very best that they can, and they're going to stay on the job as long as they can, as long as they're infected, as long as they don't have sick leave. What do you know about the overall operation of these nursing care homes?
Well, thank you, Congresswoman. Those are important questions, and it emphasizes the need for federal policy to have accountability from nursing facilities. Nursing facilities are heavily funded through Medicare and Medicaid. It's the highest level of reimbursement by far for the nursing facility industry. And in return for that, it's important that there be accountability, that the money go to direct care staff, as you know. So to folks like Mr. Brown, the nurse aides and the nurses who are there day to day providing care, it's important that there be accountability, and that also that there be accountability for violations as well, so that facilities are properly experience consequences for poor care. There's multiple reports, the GAO report I mentioned earlier, but many others that we don't have. The demonstrate persistent poor care in the nursing facility industry. Just be clear, there's some that do a really good job, but there's many others that just year after year stumble along, providing essentially substandard care. That's the status quo. And so it's important that those facilities change, that the money go to direct care and not to real estate or corporate entities that are set up to accept management fees.
But thank you very much. The gentlelady's time has expired. Thank you, Ms. Waters. The chair now recognizes for 5 minutes Mr. Jordan.
Thank you, Mr. Chairman. Mr. Kerpen, Governor Cuomo and the governors from the 6 other states you referenced did it exactly wrong, didn't they?
Yes, they did.
They put older Americans infected with COVID-19 back in nursing homes, back with the most vulnerable and at-risk population on our planet. Is that right?
That's right.
And they didn't just, in the case of Governor Cuomo, they didn't do it for 1 day, 2 days, 3 days. Governor Cuomo had this policy in place for 46 days. Is that right?
That is right.
I mean, I think about next to defunding the police, this may be the most ridiculous policy thing I've ever seen, policy decision I have ever seen from Democrats. And any person sent from a hospital to a nursing home was, in New York's case, was prevented from being tested before they went back to the nursing home. Is that right?
They could not require a test. That's right.
They couldn't require a test. So they're taking the most at-risk people, putting them back with the most at-risk people, and wouldn't even let them be tested before they allowed that to happen. Yes. This is crazy. And as Ranking Member Scalise has pointed out, Mr. Kerpen, this was a direct violation of CMS and CDC policies and guidelines. Is that true?
Yes.
I cannot. I mean, when in the history of the country, is there any other time where we would say someone with another, not COVID-19, but another contagious disease, contagious illness, should be sent back to a nursing home?
I can't think of another example. It's very unusual.
This is crazy. So the right decision, of course, oh, you mentioned something earlier. Supposedly the reason they did this was hospital capacity concerns, right?
That's what they said, but they were warned at the time they would have the opposite effect because they would create more infected patients at the nursing home and then they'd have to flood back to the hospital. So what happened was
exactly. That's common sense. Oh, and plus in the case of New York, they had the Javits Center and they had the Comfort, the Navy ship parked in the harbor. So it made absolutely no sense. Now, maybe they mess up for a day or two, but in the case again of New York, he did it for 46 days. 46 days. He put the most vulnerable population at risk in a place where other of the most vulnerable population are residing. I just find this.
And they still won't give us honest numbers so that we know how many of the deaths that occurred in New York were among the nursing home population. They only give us the people who died in the nursing home.
Right. Well said. Some people did it right. And the best example is the one you point out in your testimony is Florida. And Governor DeSantis said, we're not going to do that. In fact, here's what Governor DeSantis did in Florida. He said individuals seeking to enter a facility under Section 1 will not be allowed to enter if they meet any of the screening criteria listed below. So in order for, and here's what he puts there, if they've been in an airport the past 14 days, if they've been on a cruise ship, they can't go to a nursing home. He said if they've tested negative for coronavirus, not once, but they have to test negative twice before they would be allowed to go back into a nursing home. He put in place the right kind of policies, and that's why the numbers in Florida are so much better than in New York and the 6 other states that you referenced in your testimony. Is that true?
Yeah, they're much better. There are still a lot of deaths there, though, which I think gets to the point that Professor Grabowski was making, that you can't prevent this. This is going to happen everywhere, but it's the scale at which it happens where I think policy makes a big difference.
All right. Mr. Chairman, Mr. Kerpen, you said earlier that the proper approach, the common sense approach, the approach that's consistent with the data, what we should have done is isolate and quarantine this vulnerable population, not to do the across the board lockdown that so many states have done. And frankly, some states are still largely in a lockdown mode. We should have handled, frankly, the way Georgia, Florida, and other states have done it. We'd have been much better off.
Right. Well, the general lockdowns have cost about $25 billion per day to the economy. It's such a staggering sum, and we're forcing people to sacrifice who are at no risk to themselves on the theory that they might infect some older vulnerable person, but at the same time, we're not really putting the resources into directly protecting those people, which would be much more efficient and would require much less sacrifice from others.
I agree with all that. There's certainly the economic cost, but there was also the cost for doing it the wrong way. There were costs to human lives. People died because of the decisions that were made. That's the scary part. Mr. Chairman, what we need is we need to hear from the governors of these states who did exactly the wrong thing. And especially, Mr. Chairman, I think it would be appropriate we heard from Mr. Cuomo at some point about the decision he made and the wrong decision he made that he had in place for a month and a half with this vulnerable population.
Thank you very much, Mr. Jordan. Your time has expired. The chair now recognizes Mr. Maloney.
Chairman, for this very important hearing. I want to briefly respond to the unfounded attacks I have heard today on my home state of New York. The facts are clear. During this crisis, Americans have died in nursing homes in every state in the United States. In many states, more than half the deaths from coronavirus occurred in nursing homes.
So we could probably.
For example, both Ohio and Florida, and an estimated 7 to 10 corona deaths, 7 out of 10 corona deaths were in nursing homes. So this is not a red state or a blue state problem. It is a national problem, and we urgently need a national solution. And as for my home state, I grieve for every New Yorker who has lost their life in this crisis, but I am incredibly proud of New York's response. Our state followed CDC guidance, including on nursing homes, and what we lacked was strong federal support to get testing and personal protective equipment into nursing homes quickly to prevent the spread of the virus. And with that, I'd like to turn to my questions. And I'd like to remind everybody that it was on March 11th that Dr. Anthony Fauci, the top infectious disease expert in our country, told us the truth at a hearing at an oversight committee. And he said back then that the United States was already failing on coronavirus testing. And he said, I quote, "It's failing, let's admit it. It's going to get worse." And I regret to say that he was correct, but nowhere was his foresight proven to be more accurate than in America's nursing homes. And with that, I'd like to really express to Ms. Lally my sincere condolences for your loss and for what you and your family have gone through in a heartbreaking situation. And I'm so sorry for your loss. But last month, the Trump administration called for all nursing home residents and workers around the country he called on in the country to be tested for coronavirus within 2 weeks. But the administration left it up to states to acquire their own testing supplies. And an analysis by the Associated Press indicated that nursing homes in at least 25 states were unable to meet this testing goal. So Dr. Grabowski, I'm interested in your perspective. Was the guidance from the administration sufficient to ensure that every nursing home had enough testing?
Absolutely not. The guidance was not sufficient. I've actually called it non-guidance guidance, in that there was no teeth or dollars behind it. And if you don't put logistics, if you don't put costs into this guidance, if it's just simply a theoretical set of guidance for the nursing homes and for the states, it's not actually going to happen. And we're seeing incredible variation, as you just mentioned, Congresswoman, in terms of what states are doing. For example, Ohio's using the National Guard. New Jersey's requiring testing, but pushing a lot of the logistics and the costs out to nursing homes. Alabama's not doing anything in terms of these requirements. So quite a bit of variation. I would have liked to have seen federal leadership and federal, not just guidance, but actually.
Next question. In your opinion, what would an effective national testing strategy look like?
it would actually put dollars and logistics behind it. So there's nursing homes in a lot of states, even your home state, that can't get testing fast enough. They're really struggling to find the test. The federal government should have put the testing in place and actually paid for it. Now, for residents of nursing homes, they can be covered through Medicare or Medicaid, but many of the workers are sort of caught in the middle of this. So some workers are able to get their testing covered through their insurance. Others are trying to get it paid for via their nursing homes, but others are simply just left in between. And there was even a story yesterday in the New York Times of one worker making close to minimum wage who had to go and pay for her own test. That's not what we want. Let's have the federal government come in and own this issue by paying for the tests and arranging for the tests in every U.S. nursing home.
So it's clear that broad testing in nursing homes would catch coronavirus cases early and stop the spread. This simple step would save so many lives. Mr. Chairman, we need a comprehensive national nursing home testing strategy now. And I yield back.
Thank you very much. The chair now recognizes for 5 minutes Mr. Luchtermeyer.
Thank you, Mr. Chairman, and Ranking Member Scalise. Appreciate the hearing today. Obviously, this is a tragedy that's going on. It's we find that as a result of a lot of the studies that are being done over the last several months, that this is a very targeted disease. Or it's targeting individuals who have high-risk health conditions and our seniors, and many of them are in nursing homes. And obviously, when you congregate them all in one area, they're all high risk, we wind up with the problems that we have today. It's very discomforting to me that I in our briefing notes here, we look at, I think I counted 7 different guidance directives from CMS with regards to how nursing homes could help themselves and their residents with regards to how they could do something for corralling the coronavirus in their own facility. And so it seems to me like if there's more guidance that's needed, that's fine. But I think at some point, somebody needs to take advantage of that guidance and actually do it. Mr. Kirpin, you gave a lot of very interesting and informative information. I certainly appreciate that. 55% of the deaths now are from nursing homes. That's phenomenal. Wow, that's off the charts. Kids are less risk for the flu, for the COVID and the regular flu. That's an interesting number. And over 60% of deaths are for people over age 75. So it is a really targeted disease. And I thank you for that information. And one of the things that we've learned that I think going forward is because this is a very targeted disease, I think that we should be able, whether not or not, but we should be able to target the disease, especially if it's confined to nursing homes or to seniors or to folks in a high risk health condition, to be able to attack those and maintain and manage those in a way that could minimize their risk, as well as then open up the rest of society who has at less risk, as you just said, with the kids actually having less risk than the regular flu. So, Mr. Kirpin, would you agree with that statement that we probably are at less risk with the rest of society, can open up pretty well?
Yeah, I think that's correct.
What would you say we need to do to manage better the nursing homes, the risk that's there? Since I know there's been a number of folks give a lot of different ideas, but I'm curious about your ideas with regards to how we would better manage this from the standpoint of if that's where our problem's at, that's where we need our focus on.
Yeah, well, I think it starts with having the focus and the prioritization matched with where the risk is, which is to say we should not have national messaging that says everyone's at risk. This is the message needs to be really about who's truly at risk, and that's what the focus needs to be. And it's fine for the administration to put out a whole bunch of guidance documents and to say these things and to say, in documents somewhere that this is who's at risk, but it needs to be the major national focus, sustained, explained so that people get it, so they understand who's at low risk and who's at high risk. So I think that national tone setting messaging is critical. In terms of policy implementation, I think that there are generally adequate resources if the states prioritize them correctly, which is how some states have done a much better job. You don't need to be mass testing the general public and everyone who wants to go to a walk-up testing, even if they have no symptoms, if you could be using those same tests inside the nursing homes and other high-risk populations, but especially inside the nursing homes. And several European countries now have stopped broad population testing completely and put all their testing resources into the nursing homes. And it may make sense for our states to shift in that direction. So I think the resources that we already have could be much better utilized in terms of directing them to where the risk really is. But also, in terms of some of these big government programs, some of the things that are being suggested, putting more money into this, more resources, paid sick leave, that kind of thing. These are all things that as a conservative, I would normally oppose. But if the bargain is we put these resources into nursing homes in exchange for opening up the low risk activities and accurately communicating to people that they're not at risk, that might be worth considering, because the costs of these sort of blunderbuss broad lockdowns are so enormous and so incommensurate with risk that whatever we can do to address what's truly high risk, I think is going to be worthwhile if we can also open things up for the low risk.
Yeah, we had a study that we were talking about, I think, last meeting with regards to the lockdown and shutdown costs about 65,000 lives a month on the for the rest of society. And we're losing much less than that on the COVID side of the balance sheet, which I don't think this is a ballgame we should be keeping score here. But by the same token, you have to focus where your problem is. And we're having more and more people die on that other side. It certainly is significant, needs to be taken a look at. And I think one of the interesting things, I'm curious as to when you lock down the nursing homes, and Ms. Lally, I certainly empathize with your situation. My mother was in a nursing home for 7 years, and I know that while she did get good care, that there are nursing homes that don't give good care, and it's very disconcerting. But I'll just kind of get you a quick question with regards to, you made the comment that she became less, you started to see her condition deteriorate once she
Look at my
able to visit with other people. I think that's a question I would be curious to see once, if you had that as a if you saw that as a problem, where she's being able to interact. Did that cause some of her problems, you think?
What, not being able to interact with others in the nursing home specifically?
Well, even her family members as well.
Undeniably, the isolation and the loneliness was definitely a part of it. But I genuinely believe that inside the nursing home where my mother resided, they were struggling with proper staffing. I believe that there were periods of time where my mother didn't see anyone probably all day except for a food tray to be delivered, if that occurred. I really believe that her quality of care and the continuity of care was compromised very early. Combine that with loneliness, isolation, and having visits outside of a very dark screen on a window with kids covered in masks. It made for just a horrible situation.
Thank you very much. The chair now recognizes Ms. Velasquez for 5 minutes.
Thank you, Mr. Chairman. I just first would like to make some comments regarding the attack against New York states in the nation. Blaming governors and pitting states against each other to compete for scarce resources is not going to stop budgeting. Take responsibility for fixing this crisis. Look, this is the stock market today. For those who want to say that things are getting back to normal, no, it's not getting back to normal. As Chairwoman Waters stated, we have states like Montana, Arkansas, Utah, Arizona, and Texas all have seen coronavirus hospitalizations on the rise. What we lack is a strong federal support to get testing and personal protective equipment into nursing homes quickly to prevent the spread of the virus. That is why I led a letter with lawmakers on both sides of the aisle, calling on the administration to direct additional resources from the CARES Act to this facility. Those additional resources of PPE and testing will create safer conditions for our workers and seniors, not partisan politics. So let me address my first question to Dr. Grabowski. As I mentioned, I led a letter calling on CMS and HHS to prioritize the $175 billion in healthcare provider relief funds to nursing homes for PPE and testing. In your opinion, has the administration allocated those funds appropriately to support healthcare workers on the front lines in nursing homes?
No, I don't think they adequately prioritize nursing homes. I hear from many of my colleagues at all levels of within nursing homes saying they feel like they're in the back of the line, that they're the last to get these resources. And as we've all been discussing, this is where the cases are, this is where the deaths are, this is where the attention and resources should be, Congresswoman.
And Doctor, the states that I mentioned today, Arkansas, Utah, all those states that are now facing an uptick on hospitalizations, are they not following CDC guidelines?
You know, this idea that it's state policies that's driving cases in nursing homes and deaths, it's just not what's going on the ground. All of those states, if they begin to see hospitalizations and they see cases in the community, it's going to be the fact that it's going to end up in the nursing homes in Arkansas and Texas, you name it, it's going to happen. Here in Massachusetts, we never mandated that nursing homes accept individuals from the hospital who are COVID positive. Yet 1 in 5 nursing homes, so over 80 facilities here, have had 20 plus deaths. Those weren't deaths that came from the hospital and cases that came from the hospital. That was cases that started in those facilities for the most part. So I think we want to be really clear about the kind of origin of COVID in nursing homes. It's largely through staff bringing it, unbeknownst to the staff, into the building.
Thank you. Mr. Brown, after the first confirmed COVID-19 death in a nursing home, it took OSHA nearly 3 months to issue guidance that will protect nursing home workers. What can we do at the federal level to ensure the safety of nursing home workers where the outbreaks are the worst?
I want to thank you for your question. There's a lot that could have been done during this time. It took a month for them to even bring in someone to even sanitize and clean these buildings from COVID-19. And when we speak about earlier, Ms. Lally, sorry for your loss, when she stated about the correct staffing. This is one of the main things that can be done when we talk about poor care. When you have one CNA who is working and they have 15 residents, and when they come and they receive the things that they need to take care of these residents, they're given 7 towels, they're given 7 diapers. I have 15 residents. Each resident needs to be changed every 2 hours or as needed. There's no way possible for me to be able to do what needs to be done. And I'm sorry for your loss, Ms. Lally, but everything that she said, she hit it right on the head. Staffing. Staffing needs to be done, and it needs to be given to us so the care can be done appropriately the way that it needs to be done. Outside of that, the appropriate PPE, I have to stress, these things was going on before COVID. These was a problem before COVID. There were always communicable diseases, as me on the inside, that I had to protect myself from. HIV, KPC. This COVID, the only thing COVID did was rip the doors open. It blasted the doors open of a system that was already failing. And from that, we have PPE now that even if I go into the room and I change that resident, if any of those things, of the soiled linen or their feces get on that PPE, it soaks through that PPE and it still gets on my linen.
Thank you.
Thank you very much, and thank you, Ms. Velasquez.
Thank you.
The chair now recognizes Ms. Polarski.
Mr. Chairman, and thanks to all of you for being here today. Ms. Lally, I am so sorry about your mom. I agonize with you, and I'm just so sorry to hear about just the horrible thing that happened with your mom. I'm so sorry about her death.
Thanks to all of you.
Absolutely. The coronavirus pandemic has affected the whole world, but there's no question its impact is disproportionately in some populations. Nowhere is that more evident than at homes and long-term care facilities. We know that coronavirus in close quarters. We know those most at risk for complications or even death from corona are the elderly and those with underlying conditions. Sadly, these facilities combine all the worst case factors in one place. One nursing home owner in New Jersey summed up the challenge as this: you can dream about having 0 cases. The reality of how this travels, it was a matter of when, not if. When it gets into your building, it hits hard and it's vicious. It doesn't give up for a second. The numbers illustrate this sad reality. Avik Roy, who we heard from last week, and many of you today on the panel, found nursing home residents make up only 0.6% of the US population, but account for 42% of the corona deaths. Though, as you know, Mr. Kirpin, it could have been even higher. This is a global challenge too. This relatively small percentage of the population accounts for 38% of corona deaths in England and Wales, 49% in Sweden, and 82% in Canada. Since the beginning of this crisis, the Trump administration has issued 13 different memoranda and guidance to assist states and nursing homes in protecting their residents. States should also be coordinating and learning best practices from each other. For example, in my home state of Indiana, we are 5 minutes from the Michigan line. Our governor developed strike teams to dispatch medical expert to assist facilities like long-term care facilities with containment and logistics, including separating positive patients from the general population. As the nursing home owner earlier I quoted says, it's naive to think there won't be cases at nursing homes. There will. But this rapid response key that we developed in Indiana, I am so glad our governor took that action and we have much smaller numbers. The overwhelming evidence makes it clear that just about the worst possible thing anybody can do is to knowingly introduce coronavirus into a nursing home. And yet, that was essentially the policy of states like New York, New Jersey, and 5 minutes from my district in Michigan, which mandated that nursing homes admit patients who did test positive for coronavirus. So I think such an abject failure of policy should invite tough questions from those policymakers. So instead, here's what happened in the national media. The national media rewarded New York Governor Andrew Cuomo with a glowing endorsement and talk about being a presidential contender, with Michigan Governor Gretchen Whitmer received vice presidential buzz. The media was quick to condemn Florida for opening its beaches. They condemned Georgia and branded it as an experiment in human sacrifice. Yet after sending coronavirus patients into nursing homes full of vulnerable residents, Governor Cuomo was laughing it up with his brother in a softball interview on CNN, and Pennsylvania's top health official took their mother out of a nursing home as the state was forcing the homes to take patients testing positive for coronavirus. And yet, barely a peep from the national media. That is a scandal. What's the national media's excuse for looking the other way? It's hard to say they dropped the ball when so many didn't even bother to pick it up in the first place. That's why I'm so glad we're having this hearing today, to be able to ask questions. And Mr. Kirpin, just wanted to ask you, we've established, and many here have established this, that New York, New Jersey, and Michigan did not follow CDC and CMS guidelines in ordering nursing homes to accept positive patients for coronavirus. 7 states that all had policies forcing these facilities to take patients with coronavirus for almost 2/3 of the death among the nursing home and long-term care population in the US. But I just wanted to ask about the data challenges that you hinted at. You said the New York numbers could be even higher if not for a change in the reporting in April. Can you describe those changes again and how that might affect their count? Are there any other states reporting their data like this, or are they an outlier, Mr. Kirpin?
Well, through the end of April, New York had a very incomplete report, but they did at least notionally follow the same, try to count the same thing that everyone else was counting, which is the number of long-term care residents who had died of COVID-19. They did a big revision and they actually had a larger number, but they started carrying a footnote at the bottom of the report saying this only includes residents who died in the facility. So if somebody was hospitalized first, died at the hospital, New York said hospital deaths, we're not including it in our count of long-term care residents who died. Nationally, about 26% of all COVID deaths are physically at long-term care facilities, which means most of the, more than half of the long-term care deaths occur outside the facility, which is why the real New York numbers probably at least double.
Thank you, sir.
Gentlemen, time has expired.
Thank you.
Thank you very much. The chair now recognizes Mr. Foster for 5 minutes.
At the
You need to
heart of our
unmute,
ability
Mr.
to
Foster.
protect public health. Yes, am I audible?
Yes, we got you now.
Okay, great. At the heart of our ability to protect public health and safely reopen our economy is accurate, timely data. We need data to know where cases are spiking, which hospitals are at risk of being overwhelmed, which nursing homes are in trouble, and where medical resources should be allocated to save the most lives. We all know that nursing homes have been especially devastated by COVID. At one nursing home in Joliet, Illinois, in my district, we lost at least 26 lives due to COVID-19 this spring, all caused by one super spreader, a maintenance worker with no symptoms who was not wearing a mask because of the nationwide mask shortage, and he was not tested because weeks after Trump's promise that anyone who needs a test can get a test, there were no tests available. Perhaps there were COVID tests available for occupants of the White House, but there were none for nursing home workers in Joliet, Illinois, 26 deaths. Now, CMS is the federal agency responsible for ensuring that nursing homes around the country are safe. It is supposed to collect data, to provide guidance and oversee inspections. With more than 40,000 Americans losing their lives to nursing homes, that job has never been more critical. However, I understand that CMS is not even collecting a complete set of data on the scope of the outbreak at nursing homes. This is on top of the decision made by some governors, and not just the governor of New York, to hide their nursing home data, presumably because they did not like what the data said. Dr. Grabowski, why is it important for the federal government and the American people to have comprehensive data about the scope of outbreaks at American nursing homes?
Thanks. Good public health requires good data. And similar to Mr. Kirpin, my team here had to work really hard to piece together the cases and fatalities in nursing homes going back to the beginning of this pandemic. Unfortunately, CMS was really late to this party. They didn't release their data until May, and the data is incomplete prior to May 8th. And so that really creates a huge hole in our understanding of COVID in nursing homes. How do we know what's working across different nursing homes in different states and what's not working if we don't have the right data? So basically, we've been flying blind with respect to COVID in nursing homes. And CMS has really left this huge hole in terms of the historical data back to the beginning of the pandemic in March.
Yeah, Mr. Carlson, I'd like to turn to you. CMS is supposed to ensure that each nursing home has enough staff and follows appropriate infection control techniques, such as wearing masks, appropriate PPE, and hand washing. And it is empowered to take action against nursing homes that have persistent or dangerous deficiencies. But as you mentioned, a recent GAO study found, quote, infection control deficiencies were widespread and persistent in nursing homes prior to the COVID-19 pandemic. And as you mentioned, GAO found that 82% of nursing homes had been cited for infection control and prevention violations over the past several years. So, Mr. Carlson, why are infection control problems so pervasive in nursing homes?
One thing to note in talking about deficiencies is that the system generally records them as no harm. They don't result in any meaningful penalty whatsoever. And that allows, in situations like those cited by the GAO, for these violations to continue year after year after year. There needs to be some meaningful enforcement so we don't just look at the report and say, this is happening every year, but we're able to go and say, this can't happen every year. We can't let this happen. It obviously the consequences just can't be tolerated.
Yeah, well, in your opinion, if CMS had taken enforcement of federal standards at nursing homes more seriously before and during the pandemic, could we have averted some of the devastation that we're seeing at nursing homes?
That's certainly part of it. There's obviously, as this discussion illustrates, a lot of variables here, but better infection prevention, better staffing, those are certainly big pieces of the problem or big pieces of the solution if those practices were to improve going forward.
Well, thank you. And the Trump administration needs to provide stronger oversight of nursing homes. And the administration has to start collecting critical data and hold nursing homes accountable when they fail to meet federal standards, so we can help prevent more of these unnecessary infections and deaths. And Dr. Kerpen, Mr. Kerpen, I will be asking you a question for the record about the scientific basis of why you refer to it as a theory that young people can infect older people with COVID-19. Seems to me that's pretty much a scientific fact, and I yield back.
Thank you very much. The chair now recognizes Mr. Green for 5 minutes.
Thank you, Chairman Clyburn and Ranking Member Scalise, and thank you to our witnesses today. Ms. Lawley, I want to also extend my deepest sympathies and condolences for your loss. Honestly, it sounds like some potential malpractice in that nursing home, and I'm hopeful that your state inspectors are notified and digging into that. By now, it's become clear that elderly Americans are at a much higher risk for COVID. According to the CDC, 8 out of 10 deaths reported in the United States have been in adults age 65 and older. Tragically, residents in nursing homes are particularly susceptible. According to CMS data, as of June 10th, as we've said today, there have been 95,000 plus confirmed cases among nursing home residents, 58,288 suspected cases, and 31,782 deaths. Due to the great risk COVID poses to nursing homes, the Trump administration's coronavirus task force has taken protective steps at the onset of this crisis to protect nursing homes, residents, and workers. In early March, the administration advised nursing homes to suspend all medically unnecessary visits to help slow the spread. The administration also prioritized the shipment of PPE and supplies to these facilities where they were critically needed. As of June the 3rd, FEMA had made 9,262 deliveries of medical supplies to nursing homes in 50 states and 3 territories. Additionally, FEMA is currently coordinating 2 shipments that total 14-day supply of PPE for all 15,400 Medicaid and Medicare certified nursing homes. Many states have stepped up to the plate as well. My home state of Tennessee has been working night and day to protect our most vulnerable neighbors. In March, the Tennessee Department of Health began requiring all nursing homes to alert state health officials if they detected 2 or more cases of the coronavirus among residents or staff. In April, the department rolled out an hour-by-hour action plan for nursing homes to help stop the spread and mitigate outbreaks. Unfortunately, not every state did it the right way. Some states completely failed their nursing homes. And of course, we've talked about New York being a prime example. Other members have already hit the failure of several governors to follow CDC guidelines and President Trump's task force guidelines and the resulting deaths. And I'd like to take a few seconds and quote some of those leaders, some of those governors' overall flippancy about the virus in the first place. In February, despite the coronavirus spreading across the globe, Governor Cuomo blatantly dismissed the coronavirus and told his state citizens, and I quote, "Catching the flu right now is much greater risk than anything that has anything to do with coronavirus," end quote. The mayor of New York City, the clearly ground zero for the United States, Bill de Blasio, followed suit and tweeted on March the 2nd, that's a full month and 3 days after the president closed travel from China, Mayor de Blasio said, and I quote, "I'm encouraging New Yorkers to go on with your lives. Get out on the town despite coronavirus," unquote, and then suggested residents go to the theaters and the movies. Nowhere was this nonchalant attitude more deadly than in New York's nursing homes. On March the 21st, the state told nursing homes that it didn't need to test symptomatic residents. That led to overall testing ending in those nursing homes completely. Later in March, New York ordered nursing homes to admit patients regardless of their COVID-19 status, which was a recipe for disaster. Many New York nursing homes were self-reporting an inability to safely take in those residents. The state effectively forced understaffed nursing homes to violate CDC guidelines. Further, the state actually prohibited nursing homes from testing a resident for COVID-19 prior to admission. This wasn't just bad leadership. That killed people. Governor Cuomo didn't reverse his order to force COVID patients back into nursing homes until nearly 2 months later, as has been said. Other states like Michigan still haven't reversed that order today. As a result of the volunteer state's proactive steps and New York's failures, you can see the disparity. Tennessee has 12.1 coronavirus cases per 1,000 nursing home residents, while New York has 111. We've had 3.6 deaths per 1,000 nursing home residents, while New York has 43.9, over 12 times as many. These aren't just statistics. These are human lives. The vast majority of the deaths in this nation are elderly, with the vast majority of those elderly dying in nursing homes. And the vast majority of those dying in nursing homes in the 7 states who blew off the CDC and the president's task force. That paints a pretty clear picture of where this committee needs to direct its oversight microscope, and I hope we will. A quick question for Mr.
Mr. Green, you've exceeded your time. I will allow this one question, but you've exceeded your time.
Thank you. Just a quick question for Mr. Creppen. Any reason why the Michigan governor won't reverse this? I mean, her colleagues, her fellow colleagues, other Democrat governors have reversed this bad decision. Why is she continuing?
Well, she's in a little bit of a political sort of tug of war with Republican legislators who want to revoke some of her emergency powers, and she seems to be holding up altering the nursing home policies as sort of part of that back and forth would be my best guess. I don't think there's a very good policy reason.
Thank you.
Well, thank you very much. Mr. Rasketh is now recognized for 5 minutes.
Thank you, Mr. Chairman. The egregious failure of the Trump administration to develop a coordinated national strategy to combat the COVID-19 virus in nursing homes is just a tragic microcosm of its egregious and lethal failure to develop a comprehensive national strategy to defeat the COVID-19 crisis in the United States of America. America now leads the world in cases of infection and deaths from the disease. We now have more than 108,000 people that we have lost in this nightmare, although you'll never hear any of our colleagues mention that number. And still, the Trump administration has no nationwide strategy or plan for testing, contact tracing, and boxing in the virus. Where is the plan? When the Obama administration confronted the Ebola crisis, he appointed a czar, Ron Klain, and set up a nationwide plan to defeat the Ebola virus. We lost 2 Americans. And the Republicans still denounced President Obama and railed about his incompetence and called for his resignation. This crisis is more than 50,000 times worse and counting. Now, I suppose it's progress, Mr. Chairman, that today the ranking member and Mr. Jordan and their colleagues, our colleagues on the other side, find that there is some official governmental responsibility for dealing with the crisis. Today's GOP robotic talking points are not about the World Health Organization or about the Chinese government or Donald Trump's very good friends in the Chinese Communist Party. Today's official talking points are about actual US governmental officials. So that's progress. But what do you know? It's Democratic governors and mayors that they are blaming for the crisis today. How gullible and ignorant do they think Americans are? It took more than 2 months after the first outbreak in a nursing home. And one of the first ones was in my district in Carroll County at Pleasant View, where more than 100 people were sickened and we lost 28 people. But it took more than 2 months after the very first outbreak for the Trump administration on May 11th simply to urge residents and staff of nursing homes to be tested. And that wasn't developing a plan to do it. It was just a word saying you guys should be tested. And there's still no nationwide testing plan, contact tracing plan, enforcement plan. It's just talk. It's just rhetoric. For months, the nursing homes pleaded for PPE and testing kits from the federal government and received nothing, a couple of photo ops and some meager assistance from the federal government. In late April, FEMA announced it would coordinate the shipment of a 2-week supply of PPEs to nursing homes. Great. It hopes the supplies will arrive at the beginning of July. This is the country that defeated fascism in World War II. This is the country that sent a man to the moon, and the federal government seems completely inept and helpless. Dr. Grabowski, Dr. Kerpen, or I heard someone say Mr. Kerpen, I hope we clear that up and see which it is, but Dr. or Mr. Kerpen repeatedly referred to people who are not at risk from the virus. And he also suggested that the stay-at-home orders that were issued by both Republican and Democratic governors, like my Republican governor in Maryland, Larry Hogan, were unnecessary. But I've read scientific data suggesting that those orders are the only thing that's worked to save millions more people from being infected and tens of thousands more deaths. Which is correct there, if you could clear that up for us?
Absolutely. So the lockdown certainly flattened the curve in many states and did save a lot of lives. And indeed, you could imagine the discussion we would be having today about our nursing home residents and their staff if we hadn't had the lockdown and this had been allowed to sort of run unfettered through these communities. If we didn't do anything to sort of invest in protecting nursing homes and allowed kind of this escalation of cases in the community, it would have been even more dire than the discussion we're having today.
Mr. Brown, thank you. Mr. Brown, we're reading of these tremendous staff shortages that have arisen at nursing homes and long-term care facilities. And I know a lot of people there are being paid $14 or $15 an hour. I don't know exactly what you earn, but it's really just above the poverty level that people are being paid. Can you describe why there are staff shortages? Some people are saying it's because the for-profit nursing homes are firing people. Is it just because it's hard to recruit people to do this difficult work? How do you explain it?
Thank you for your question, and that's a good question. One thing I can say is when it comes to it and hiring these people, I can speak to it like this. When COVID-19 broke out, my brother, he works at Mariano's. He's a cashier at Mariano's. Everybody's job is equally as effective, but the minute that COVID broke out, his job at Mariano's raised him up to $18 an hour. At that time, I was at $13.90. We're expecting people to come to work and put themselves at risk for a pay that's not worth it. We have people in my building that has been working there for 40 years, and when they retire, their retirement check will be less than $150. So when we speak to keeping staff in the building, we're not going to be able to do that when we're not paying them what they're worth, and we're calling these people heroes. That's not going to cut it. Not having the testing in the building. I still have not been tested. You don't know if I have COVID or had COVID or whatever the case may be. I'm still coming to work and I'm still working with these people. I could have passed it. I don't know because there's no way or no means for testing. So when we talk about keeping staff in the building, currently right now, the governor did pass something to allow TNAs to come in the building and help, but that doesn't cut it because when they don't have the education or the background, nor have taken the state board to do the job that we're doing, to do it effectively and correctly, there's a lot of things that they can't do. Yeah, they can pass trays, but they can't feed people because you have to be trained on how to feed people, making sure that they're swallowing, not giving them too much of the food, knowing those types of things. So, I mean, they're bringing in untrained people for the help, but it's not helpful because they can't change, they can't feed. All they can really do is pass trays. So speaking to staffing in itself, what needs to happen if we want more staff and better staff, one, people go to school and they have to take a state board for this. They need to raise up the pay that these CNAs are getting. I can go to McDonald's and flip a burger and I can make more than I'm making than taking care of doing the backbreaking work of taking care of somebody's family member.
Thank you very much.
And that's what we need.
Thank you very much, Mr. Brown, and thank you, Mr. Raskin. The chair now recognizes for 5 minutes, Mr. Kim.
Thank you, Mr. Chairman. Appreciate you calling together this briefing. I wanted to start with a question of Mr. Kirpin. Mr. Kirpin, you talked about a lot over the course of this briefing about several states and the policy decision made regarding the transfer of patients to long-term care facilities, if these patients may have been positive with coronavirus. In the states that you cited, I want to ask you how many coronavirus positive patients or patients that had coronavirus were actually transferred to long-term care centers? And how many additional positive cases were a result of those transferred? How many of those were of these cases that we saw in these 7 states responsible through the mechanism you talked about?
I don't have data on that. I haven't seen any report that reports I haven't seen any state that reports the numbers that way, but that would be very interesting data to have that we should request from those states.
Yeah, I agree with you on that front. Yeah, I'm a data guy as well, and what I'll say is that we really want to make sure we're thinking through this, trying to understand what the causality actually is. And when I think about what do we actually know? What we know is that, at least from all the long-term care centers I talked to in my district, as well as what we've heard around, that we know that they did not have enough personal protective equipment. I think we can draw a very straight line between the causality there. Mr. Brown, I wanted to ask you a quick question here. You said you didn't have enough PPE before for yourself and for a lot of your coworkers. Now, I'd like to see it right now. Do you have enough right now? Do you have enough guaranteed right now in the event of a second wave of this virus later this year?
In a second wave, no, we don't have enough for a second wave. And there's a question if the PPE that we're getting is even effective. Because as I stated before, I can go in and do the care. That PPE gets wet or soaked at any point. It goes through that PPE and it still gets on my clothes,
Yeah.
on my
Mr.
scrubs.
Mr. Carlson, I wanted to turn to you because you have a wider perspective here across a lot of different long-term care centers. Have you known of any long-term care facility that had enough PPE during the height of this epidemic? And do you think that they have enough right now to be able to prepare for a second wave?
It's possible there may be some facilities out there that have been adequately supplied. But in general, I think the panel here is fairly unanimous on this question. It seems that there hasn't been enough PPE in the system. It hasn't been distributed in a comprehensive manner. And I'd submit that the shipments of from FEMA have been a bit late and inadequate. So I can't speak to every facility, but certainly system-wide, it's been a tremendous problem for facility, even to the extent that surveyors have ceased activities in a lot of cases, that the state surveyors specifically note that they would only do inspections if they had adequate PPE, and oftentimes they recognize that they don't. And so as a result, they've curtailed their activities.
Yeah. So that's helpful. So in large trend, not having enough PPE before and still potentially having continued problems on that front, especially in the face of a second wave. Dr. Grabowski, I wanted to ask you, so we know that we don't have enough PPE. We know that we didn't have it. We still don't have enough. I think another area where I've seen pretty widespread consensus here is that we don't have enough data, that we're struggling to be able to get that. So I'd love to just hit this to you. What is it that we're missing still in the data set?
Absolutely. So the federal government put a lot of resources into putting together this what they thought would be a comprehensive COVID database of all cases and deaths. Yet the real missing piece is that they made it optional for facilities to report cases and deaths prior to May 8th. Well, that's not really useful because, as we've been talking about, there's states like New York and New Jersey that had a tremendous number of cases. So that's a big hole. And we're still waiting on about 20% of facilities to actually report their current data. And then the final point, we're hearing about a lot of data errors and a lot of facilities that have values that just don't fit with experiences of family members and staff that are working in those buildings.
Thank you. So I just want to make sure we're following the causality here directly. Understand that the problems of PPE, of the lack of data, as Ms. Lawley talked about, the lack of communication and the staffing issues on that front, all coming together. And I think some of the other issues that were raised, we need to see more data to be able to draw that line. But Dr. Grabowski, just want to end with you here. You had a line in your statement that was just very strong. It didn't have to be this way. I agree. And I wanted to just ask, who is fundamentally responsible for responding to this crisis? The federal government or the states?
The federal government. This has to be an issue that the federal government owns in terms of testing, in terms of personal protective equipment, in terms of support for our workforce. The buck has to stop there, and it didn't. It got pushed off to the states or pushed off to the nursing homes. We've had far too many gaps here, and we going forward, this is the time for the federal government to own this and really put together a comprehensive response.
Great, thank you.
Well,
Thank you, Mr. Chairman.
Thank you very much, Mr. Kim. Before closing, the chair will recognize the ranking member for any closing comments he may want to make. Mr. Scalise? I think you're muted by somebody.
Okay, yeah, I think they just unmuted me.
Okay.
All right, we on? All right. Thank you, Mr. Chairman. Again, thank the witnesses for their testimony. And I'm glad we finally got to start getting into talking about the data. There's a lot of data out there. Frankly, there are still some states that aren't giving us the data we need, and we've called on New York and other states. There's a letter, again, that I talked about in my opening statement that I'd like every member to sign off on to ask for that data, to get more information, because we've seen while this disease is out there throughout the country and it's impacted so many different areas, seniors in nursing homes have been by far the most disparately hit in a devastating way. About 40+%. Some reports say it is even higher. Again, if we get that data, we'll know that at least 40% of all the national COVID deaths are from seniors in nursing homes, which represents 0.6% of our population. And now that we have that data, again, our job should be to find out as much as we can about how the money is being spent, how we can stop more people from dying, how we can get our economy back open safely. But we know, Mr. Chairman, right now there are still seniors dying in nursing homes because of some of these orders. And it boggles the mind. And I know a lot of people talked about testing. Uh, Look at the order from the governor of New York in March. Literally, nursing homes, this is his language, are prohibited from requiring testing, prohibited them from requiring testing. Thousands of people died. Now, fortunately, the governor of New York rescinded this, but as Mr. Jordan talked about, it took 46 days. Thousands more people died. Nobody, by the way, none of our members or witnesses disputed that these were deadly orders. Nobody said these were good orders for the governors to give, yet they gave these orders. Again, New Jersey's language is almost verbatim from what we saw in New York. Literally, nursing facilities are, quote, prohibited from testing. In Michigan, and this is the worst, because not only did they prohibit that, they're still doing it. Mr. Chairman, we ought to have the governor of New York come and talk about what really happened, why they did this, and why they aren't sharing the data properly with us, so we can make better decisions to help share information and stop more deaths, most importantly. But we also ought to have the governor of Michigan come and talk about why she won't reverse this. I mean, if this is about somebody being stubborn because they gave an order and they don't want to look like they did the wrong thing, people are dying today in Michigan for no reason. It needs to end. Let's call it a bipartisan initiative. Who cares whose idea it is? We know now the consequences because we have the data, and people are dying from these orders. It didn't happen everywhere. You know, we could bring in the governor of Florida and he could talk about what he did following CDC guidelines. CMS gave 14 different guidances, 14 different times. CMS helped nursing homes in states figure out how to do it. Nursing homes have always been run by the states. That's not something that the federal government owns. States do this, and the federal government gave guidance. They gave 14 different sets of guidance. Most people followed it. Republican and Democrat governors alike followed it, except some didn't follow it. Why they didn't follow it, I don't know. We ought to find out, because people died. Thousands and thousands of seniors in nursing homes died for no reason because that guidance wasn't followed. We ought to find out about that, Mr. Chairman. With that, I will yield back.
I thank the ranking member. In closing, I want to thank all of our panelists for being here today to help bring attention to this tragic situation as it continues to unfold. We are particularly grateful to Ms. Allison Lally for sharing her family's personal heartbreak with all of us. On behalf of all of us, I want to extend my condolences to you and your entire family on the tragic loss of your mother. I would also like to extend special thanks to Chris Brown. Mr. Brown, you are truly one of our nation's frontline heroes, and we are grateful for all that you do to care for and protect our nation's most vulnerable residents. I also want to thank the ranking member, Mr. Scalise, for all of my colleagues on this committee for their participation and contributions today. I know that you all share my deep concern and sadness about what is happening in our nation's nursing homes. Today's briefings made clear that there are steps that we can take now to help prevent the tragedy from getting worse. First, we need the federal government to ensure our nursing homes have enough testing and personal protective equipment to stop the virus from spreading. That means providing coordination and resources, not just leaving it up to the states. Second, we need strong oversight of nursing homes to ensure they have better infection control and enough staff to properly care for our residents at all times. Third, we need to make sure that essential workers have fair pay and paid leave. And I might add, after listening to Mr. Brown, and testing, so that they are not forced to show up to work sick. We have seen far too much suffering in nursing homes during this crisis. It is time for us to come together and provide solutions to bring this tragedy to an end. And I would hope, in spite of all that I have pleaded for, the fact still remains. We need to get beyond partisan politics. I don't care whether these statistics are coming out of New York or Texas, coming out of New Jersey or Utah, coming out of Florida or Arkansas. The fact still remains. This virus knows the color of no state. This virus knows nothing about which party one may be a member of. And yes, we can hear from the governor of New York, but nobody calls here today for the governor of Texas. And I've seen the numbers coming out of Utah. I'm not interested in making anything partisan out of this, or of Arkansas. This is about us doing what's necessary to protect Americans, irrespective of stations in life, irrespective of skin color, irrespective of party affiliation. We are one America. And let's try to act that way. And I close this briefing. Thank you. Thank you, because I'm about to move.